Shake.
Go ahead.
Okay, so thank you everybody for coming, and we're going to talk a little bit about cryoablation and just, I don't have any videos or anything. It's actually very easy to get a conceptual idea of what cryo is about. You can literally type in YouTube, cryoablation, atrial fibrillation, and you'll see a very nice video. But essentially, what we've done for the last 7-8 years has been radiofrequency ablation, where we use heat energy to make scars in the left atrium around the pulmonary veins to electrically isolate the pulmonary veins from the rest of the heart. The pulmonary veins are a primary initiator of atrial fibrillation. They fire rapidly, then the left atrium fires rapidly, and you go into AFib. So cryoablation, which has been out for a while, we just started doing it 3 weeks ago. It's different in the fact that we freeze tissue, again, to make a scar. So the end result is to make a scar around the pulmonary veins, but we're using cold temperatures instead of heat energy. The advantage of cryoablation is, in general, the length of the procedure is shorter. With radiofrequency ablation, in general, we can get them done in about 3 hours. With cryoablation, you can expect to be an hour to an hour and a half. So it's a quicker procedure. So usually we do 2 radiofrequency ablations in a day. With cryo, we can probably do up to 3. So we should be able to increase our volume, less time patients on the table. As far as efficacy is concerned, as far as trials are concerned, there's one famous trial called the Fire and Ice trial. That actually showed the efficacy between cryo and radiofrequency ablation is about the same. That being said, anecdotally, when we talk to practices that are using cryo, they actually feel that the efficacy is slightly higher with cryo. But there's no data to prove that, so I've never say that to the patient, but kind of anecdotally, that's what people have told us. So as far as teaching the patient, as far as risks and benefits, the risks of a cryoablation are going to be the same as radiofrequency ablation. And the risks are what scare people. And what I tell people is, whenever we do an electrical study, the following risks are present. Bleeding, infection, vascular damage, myocardial perforation, a catheter or something could poke a hole through the heart, causing pericardial effusion and tamponade, stroke, heart attack, and death. This rolls right off my tongue. Specific considerations with an AFib ablation, and this could be cryo or RF, are pulmonary vein stenosis, narrowing of the openings of the pulmonary veins, atrial esophageal fistula, cause a connection between the esophagus and the atrium that could cause you to vomit up blood, or worse, suck in air and bacteria from your mouth and esophagus that goes into your bloodstream. It goes to your brain, causes stroke or infection. So in order to reduce that risk, we put a temperature probe down the esophagus. If we're doing RF, we see too much heating would come off, and with esophageal or with cryo, if the temperature goes too low, we actually have to come off the freezing. Can cause damage to the mitral valve for primary repair replacement. And what was the last thing? Atrial esophageal fistula and phrenic nerve damage. Now, the phrenic nerve, that is one thing that cryo has. There's a higher incidence of phrenic nerve damage with cryo compared to RF. There are maneuvers you can do to minimize that, and we do those maneuvers. We pace the diaphragm as we're doing the ablation. We actually monitor the diaphragm electrically. In 3 cases done so far, we've not had any phrenic nerve issue. Anecdotally, talking to the practice that we visited a year ago, they told us that actually anyone who's had phrenic nerve palsy with cryo, they've yet to see one that the phrenic nerve did not get better. So for whatever reason, there's a lot of theories about this. With cryo, for some reason, it usually is a reversible process if people have a phrenic nerve damage. But it is something that we're aware of, that it is a higher incidence compared to radiofrequency. As far as patient education and setting up the procedure, it's essentially the same. We're still getting CAT scans on these procedures. We're still doing our anticoagulation med hold like we would for RF. The only thing is that we don't need a mapping system, so when we use radiofrequency ablation, we would call CARTO, or Biosense Webster. With this procedure, there is no mapping. So we have to call the vendor, we have to call Medtronic. So when this gets scheduled, we have to make sure the schedulers know this is a cryo case, because they're going to call Medtronic. If it's radiofrequency, then they have to call CARTO. So that has to be definitely clarified when we say AFib ablation. Oh, what kind? Cryo or RF? That way, at least you know which vendor to call. Follow-up will be the same. That's pretty much it. So, shorter procedure time, no mapping system used. It will use more fluoro. I didn't mention that. The fluoro time will be higher with cryo. It's going to be especially high at the beginning because we're kind of getting used to it, but that number will, I think, fall pretty dramatically over 2018. But as far as what the patient's concerned about, as far as the prep, what to do about the blood thinners, the risks, essentially all the risks are the same. It's just a little bit of a difference in the phrenic nerve.
I know you've only done 3, but if they come back and have a recurrent AFib, what do you do then?
Well, what we're probably going to do is do CARTO, because we want to map it at that point and see if there's scar. Talking to the group that does a lot of them, they actually found that every time they would see recurrence after cryo, it wasn't because the pulmonary veins were not isolated. They said those veins were always isolated, and basically the AFib was coming from somewhere else, and they actually quit doing repeats on these people. We will probably initially restudy these people and just see if there's a breakthrough, but that's to kind of be determined later. Hopefully we have very few of those.
Is there a maximum number of repeats you can do on somebody?
In general, locally we will do 2 on people. We'll do 1 and then maybe a follow-up. If it gets to needing a 3rd ablation, we will sometimes refer them out to IU or a tertiary institution for what we call rotor mapping and ablation or firm ablation. There's technology, even though we think AFib is chaotic activity in the upper chamber, there's data to show that it actually goes around central rotors. And there's special mapping catheters that can determine where these central rotors are. When you burn those rotors, some studies show there's an incremental benefit in the success rate. There are some follow-up studies, however, that show there's no difference. I probably sent a total of 3 people down to IU to get cryo. 1 has done extremely well. The guy had 2 ablations here, kept having fib, went down to IU, had a rotor mapping ablation. He's done great. 1 person that I can recall off the top of my head, she still has AFib despite of that. But in general, we will do up to 2 here locally for fib. Now, anytime anyone has an ablation for fib, they do also have a risk of having what we call macro reentrant arrhythmias or flutters. Not necessarily your typical flutter on the right side, but a flutter on the left side because of the scars that we've made on the left side. So that's a totally separate category. So some people might go back 2 or 3 times because they're having macro reentrant tachycardias, not necessarily repeat AFib ablation.
I wanted to talk about the phrenic nerve for phone triage. What symptoms would a patient call in with phrenic nerve?
Will primarily be shortness of breath. So, someone has shortness of breath, and that would be fairly evident, like right away, because the phrenic nerve gets knocked off in the lab. And most of the time, we'll probably know it ahead of time. We'll know post-op data that the phrenic nerve got hit because we're feeling for the phrenic nerve as we're performing the ablation. All of a sudden, you lose the phrenic nerve, and we'll test to see if it comes back or not. And we may get a chest X-ray the next day. Chest X-ray is diagnostic because they have elevated hemidiaphragm. So that we'll know right away. The one that is a delayed risk is the atrial esophageal fistula. And I've talked to the ER doctors about it periodically, and that occurs 2 to 4 weeks following the procedure. And people can just have fevers, they can have pericarditis symptoms, they can have stroke-like symptoms. And the key is, if they're having hemoptysis or hematemesis, is to not perform an EGD or a TE because when you shove a probe down their esophagus, you're pushing in air, and then that causes a big problem. The key test to get is a CT scan of their chest, looking for an atrial esophageal fistula. And the radiologist will actually miss it as well, unless we literally go down the room and say, this is what we're looking for. Knock on wood, we have not had one here that we've performed. There was one case done in an outside hospital that was transferred to Randalia, was transferred to Randalia that had that complication and was not recognized right away.
Do you want to talk a little bit about the indications for sending patients for evaluation?
Yeah, so most of the patients that we see for ablation are have failed one antiarrhythmic drug. So we really love the paroxysmals, right? So the people that have episodes of fib, most of the time they're in normal rhythm. They have an episode where they go in the fib for hours or a day or two, and they pop out of it on their own. Those are the ideal patients. Those are the people that are going to have the high success rate. When your physician sends us a patient that's been in AFib for the last 2 years, and their left atrium is 5.5 centimeters, and you want us to fix it, you know, some of those people, selected people, will try it, but their success rate is much, much lower. We want them early, so it would be helpful if you nudge your physician, you know, if someone's got AFib, and, you know, they're on Multac, they're on something, and you know they're still having AFib, and the doctor's like, oh, you know, see you again in 6 months. It'd be nice to make that suggestion to send them our way, because we can help those people. And we can do it, but we need to do it sooner rather than later. I see a lot of patients where it's just too late. I talk to them and I say, you know, we can do it, but I don't have a high degree of optimism because you were sat on too long. So, paroxysmals are ideal. We will do persistence, but you know, don't send us the 85-year-old lady in the nursing home who's got dementia, doesn't even know she's in AFib. That's just a waste of my time. It's a waste of her time. We want the younger patients that are functional, not on 4 liters of oxygen, don't weigh 400 pounds. You know, don't send us those people, please. Any other questions at all? So, okay, well thank you, and hopefully the handout. Oh, go ahead.
WPW, you do these for that?
No, so the cryoablation is this balloon. There's a picture on the back. So we put in this lasso, or it's called cheek catheter, and then you occlude the vein and you freeze the opening, okay? So that's how we're doing this cryo right now. Versus the previous page, page 3, shows you what we do with an RF ablation. We have 2 separate catheters. One's called the lasso, looks like a lasso, and then you have the straight catheter, which is the burning. WPW, though, we're still using radiofrequency ablation. However, there is such a thing as a cryo catheter, which gives pinpoint areas of freezing to destroy tissue. The only people that we would potentially use that for is people with a parahisian accessory pathway, someone who has an accessory pathway that's right by their AV node. So, but none of us have been trained on the specific catheter yet. I've referred 2 patients out of our hospital because they've had an accessory pathway that was right next to their AV node, and I didn't want to. No, I burned there, but then it was causing damage to the AV node, and I had to stop. I had to send them to get cryo. To get cryo for an accessory pathway in that situation, the advantage is you start freezing, you start seeing damage to the AV node, you can start re-thawing, and then the AV node conduction comes back. So the answer is yes and no. You can potentially do it. We're not going to as of yet until someone gets trained, and it's only going to be for very specific cases. So odds are all the WPWs are going to still be radio frequency.
What's the youngest age? Age.
Well, ideally, we would prefer patients to be under the age of 75. We've had some exceptions where we've taken some people that look pretty good that are in their 77, 78. With cryo, there are some advantages. Some people feel it's actually a little bit safer because you're just pushing a soft balloon and the procedure times are shorter. There's some guys that are at outside institutions that are taking people up to the age of 80 years old for this. I think we'll get there. We still have made some exceptions, but in general, our general rule of thumb is 75, but we have made some exceptions to that. And we've done as young as, like, I think our new record's like 27. We've done a 27-year-old with AFib. other questions? Okay, all right.
Thanks, Dr. Otten.
Thank
Thank
you.
you.
Appreciate it.
Sure.